Thank you very much for inviting me to share our first experience with the new Discovery MI scanner. Actually, the title of the talk was a bit unspecific, right? It said high sensitivity PET systems, and that was because GE wasn't really sure whether we could have any images before this meeting. Just a little history about Uppsala. I think that the first work with PET in Uppsala started in the early 1970s, before I was born, when Professor Bengt Långström started the carbon-11 chemistry program. And since then, one of the major focus of our work in Uppsala has been in implementing new tracers into the clinic. So we do a lot of things with non-FDG tracers, and that is still our focus to date. So we've done about 25 first-in-man studies, and actually we have right now about 15 tracers in routine clinical use. And I think that is a very nice thing about working in Sweden, that the regulations allow us this. If the medical staff wants to use certain tracers, we can do that, as long as we have a validated GMP production. Until about 1.5 years ago, we did all that with these 3 scanners. That the oldest 2 of them were 18 years old, so it was about time to get something new. And naturally, when we started to do a tender for 2 new PET-CT scanners to replace these 3 scanners with, we put a very high emphasis on sensitivity and on good count rate behavior, because all other things aside, you need counts to get a good image. So that's why we really figured sensitivity was the most important thing. So this is actually the Discovery MI when it was delivered in the end of August. Came about a week too late because it got lost on the mail. That can happen also with these big things, apparently. This is what it looked like before it was installed, and this is what it looks like now at the department. So we have a Discovery MI. We actually have a Discovery IQ on loan from GE before our next Discovery MI will be delivered. And we've got a SIGNET PET-MR since almost about 2 years now. So now we're completely up to date. And of course, you can't really see the differences between the IQ and the MI from the outside. If you look at the wallpaper behind them, you can, of course, see the difference. This is a very nice Swedish wallpaper we have there. But it's all in the inside. That also counts for PET, of course. So we now, we did the first scan actually only 3 weeks ago on this scanner. Having these 3 high sensitivity scanners standing next to each other at our hospital also gave us a nice possibility to actually compare the performance of these scanners in a rigorous way. Just a little overview. The Discovery PET-MR and the Discovery MI both have YSO crystals coupled to silicon photomultipliers, whereas the Discovery IQ has BGO crystals and regular photomultipliers. For comparison, I also added the Discovery 690, the previous generation PET-CT scanner, to this. And what you can see, what is especially interesting with these scanners is that they have a larger axial field of view than the previous generation. So the MI, the IQ, and the PET-MR also all have a field of view of 20 centimeters or more. So I'll give you a brief overview about the performance testing we did of this scanner and the comparison with our other scanners. And then I'll go through a number of clinical cases that we have acquired in the past weeks. So this is a team that did the NEMA performance test. As you can see on their faces, they actually succeeded, and the system passed all the tests perfectly. First, the resolution, comparing our scanners, the Signa, the IQ, and the MI, and to literature data of the D710. As you can see, the spatial resolution of the MI is about a millimeter better at the center of the field of view than the IQ, and actually it's quite a bit better than the PET-MR as well. And that is not so surprising, since they use the exact same size detectors, but the ring diameter of the PET-CT is larger, which means that seen from inside the patients, the detectors are farther away and looking smaller, so you get a bit better resolution there. These are the other results of the NEMA tests of the different scanners. As you can see, the most important part there is the sensitivity, which is considerably higher on these latest generation PET-CT scanners than the Discovery 690. Of course, it's a bit lower than on the PET-MR because of the smaller axial field of view, which is the major driver of the sensitivity. Also, you see that the peak noise equivalent count rate of both the PET-MR, but especially also the Discovery MI, is considerably higher than on BGO scanners and on the previous generation of PET-CT scanners. About noise equivalent count rate, for those of you that are not familiar with that, that is a measure of basically the contrast to noise ratio in the PET images that we get. And this graph shows the noise equivalent count rates for all our 4 scanners and for the Discovery 690. The Discovery ST is our old PET-CT scanner. And as you can see immediately is that both the PET-MR and Discovery MI have considerably higher noise equivalent count rates than the other scanners. But what is important about this graph, I think, is that when you're doing whole body FDG scans, you're down here somewhere. So there is really the sensitivity that makes the difference between the scanners, not as much the count rate capabilities. But once you're starting to do dynamic brain scans during the first pass in the brain, we're at these kind of count rates. And then these digital detectors with the faster electronics really start to matter. And if you do cardiac scanning, where you have much more radioactivity in the field of view at the first pass, then the high noise equivalent count rates really matter as well. What is also important to notice here is that the noise equivalent count rate doesn't take time of flight into account. And of course, the Signa PET-MR and the Discovery MI have a much improved time resolution compared to the previous generation of PET-CT scanners, which would actually mean that you have to multiply these curves by about a factor 2 compared to the Discovery 690 to get the true improvement in signal-to-noise ratio. So we thought when we have these scanners standing next to each other, we'll do a proper image quality comparison with a NEMA image quality phantom. It's always difficult to compare scanners when you have to refill the phantom between testing one scanner and the next one, because you can never reproduce that accurately. But now we could fill this phantom and do the same measurement on all 3 scanners without having to refill it. And of course, we did like a zillion different reconstructions to test all the new things that we have on the Discovery MI. And before I show you the results, I first have to give you, those of you who are not GE customers, I have to give you a brief overview of the GE dictionary. And actually, you don't need A to Z here, you just need V and Q. And what GE calls VPHD reconstruction is what is more commonly known as ordered subsets expectation maximization. And I will use these GE abbreviations, that's why I'm going through them briefly. VPFX means OSEM with time of flight. Sharp IR means points per function compensation in the reconstruction. So VPFXS then means time of flight OSEM with points per function compensation. And Q clear is the GE's name for what is called the block sequential regularized expectation maximization. I actually put it on the slide so that I would also remember what the abbreviation means. And so QCFXS, that means Q clear with points per function compensation. I don't think you can turn it off, actually. It's always included in Q clear. So these are 3 images of the image quality phantom reconstructed using the what we believe so far the reconstruction settings recommended by GE for clinical FDG whole body scans. On the left, the Signa PET-MR, on the center, the Discovery IQ, and on the right, the Discovery MI. And what you can see immediately is the much better recovery of the smaller sphere in these images on the 2 digital systems compared to the IQ. And that is, of course, because of the better resolution of the scanner. So if you then draw volumes of interest equal to the volumes of these spheres over the spheres, and you plot what you measure in those volumes of interest as a function of the sphere size, and you plot what you measure divided by what is actually there, you get a recovery curve like this. And that shows that the Discovery MI performs about the same as the PET-MR with these standard clinical reconstructions, and of course a bit better than the Discovery IQ because of the better resolution. Then we went on and we started to look at the Q-clear reconstructions. And what you can see immediately in the top row, the different factors below the image are the different beta factors that they call that steer the regularization in this algorithm. And a higher beta factor means more smoothing in the background, which you can very clearly see from these images. What you also can see is that the smallest lesion in this phantom is very clearly displayed in the Q-clear images, more so than in the standard VPFXS reconstruction. And that translates to recovery curves like this, where the blue line in the middle is the standard OSEM with time of flight and points per function. And all the other colored curves above it are the different Q-clear reconstructions. So by using Q-clear in this phantom, we get much better recovery of small lesions than what we get with the standard reconstruction. The 2 darkest lines at the bottom show what happens when you take off the points per function recovery and when you take away the time of flight. And then, of course, you get a bit worse reconstruction recoveries, but they are still comparable to what you got before on the Discovery 690. The the background variability, yeah, that gives a bit of the opposite effect, right? If you use less regularization of the images, you get more noise in the background, you get a larger variability. So here, a low beta factor means a large variability. And if you divide those two by each other, the recovery divided by the variability, you get something which should be somehow related to the contrast to noise ratio. And there you can actually see that the improved contrast in the Q-clear images outweighs the larger background variability. And actually for most Q-clear reconstructions, except for the one with the lowest beta factor, we see a better contrast to variability ratio with Q-clear than with the standard OSEM. So some clinical examples. How does this affect our clinical images? This is an image of one of our technologists, Hampus, doing the first scan with the Discovery MI. And this is an advantage of doing a lot of things with carbon-11. This was a dynamic scan, so after you've injected it, there's not so much to do. And it took 40 minutes. But he looks very happy, doesn't he? I took it from his Facebook page, so I think it's allowed. So the first scan we did was actually a scan with a dopamine transporter ligand that we use routinely in the clinic. And we do that because it provides us both with a relative cerebral blood flow image that you see on the top row here, and a dopamine transporter availability image that you see on the bottom row. And that looks familiar if you're used to using, for example, that scan, but with a better resolution. And I think at least those of you who are familiar with these scans can immediately appreciate the very high quality of these images. And these are not just PET scans. These are modeled images where we do tracer kinetic modeling on a pixel level. So I think this is really a fantastic quality. We tested a number of different reconstructions from the standard OSEM on the left until the two Q-clear reconstructions on the right. Actually, it's quite a good projector here. So I think you can see the improved homogeneity in the background on the dopamine transporter images on the top row. And you can also, I think that's very nice, see the improved contrast in the relative cerebral blood flow images, where the background, the white matter here, shows up as green in the standard OSEM images, whereas you get a really nice contrast, a much sharper contrast in the Q-clear images, but also in the OSEM images with point per function recovery. We have performed a number of FDG scans in patients with neurodegenerative diseases. Again, on the top row, standard OSEM with point per function recovery, and on the bottom row, Q-clear 300. And I think also here you see that these images have a very nice contrast, and it's much better than what we were used to. Some other clinical examples, whole body scans. This is, of course, a maximum intensity projection image of a 57-year-old female with ovarian cancer who got 244 megabecquerel FDG. And we scanned for 2 minutes per bed position here. And this is reconstructed using the recommended settings. I will be showing you some coronal slices just to go into the effects of the various reconstructions. On the left, you see the standard OSEM. And those of you who were at the GE event yesterday heard Dr. Ayagaru from Stanford say that the VPHD images, the standard OSEM images from this scanner, are comparable to the Discovery 690 images in terms of image quality. And then you can see what enormous improvement you get in clarity in the images for this scanner compared to the previous generation of scanners, which by no means were bad scanners, of course. So if you look at the small lesions here, they are much sharper in the MI images. And of course, there's also a number of lesions that you hardly see on the VPHD image, but that actually show up very nicely here, especially these here in the intestinal area. So we also reconstructed these with 1 minute per bed position. And I think especially if you look at the Q-clear image, there's not so much reduction in image quality when we go from 2 to 1 minute per bed position. And we, of course, have to look into this much more, but this looks very promising for being able to do very fast whole body scanning with FDG. The next case is a patient with sarcoidosis, where we, in our routine protocol, do both an FDG scan and an oxygen-15 labeled water scan to actually assess the damage to the heart by the sarcoidosis. So this patient got first a 400 megabecquerel oxygen-15 labeled water scan, dynamic, 6 minutes, to measure myocardial blood flow, followed by a whole body scan with FDG. And I just like to show you the water images. These are actual quantitative myocardial blood flow images that we calculate with our own software. And also this is modeled data. You have to do modeling on each pixel, and I think the quality of these parametric blood flow images is really excellent here. advantage of water is that we can assess both the myocardial blood flow and the perfusible tissue fraction, which is a matter of a measure of viability. And these also look excellent. And one of the reasons for that, I think, is that what you need to do with water is you need to very accurately define the input curve, that is the activity concentration in plasma over time during your scan. And this is an automatically generated clustering of the left and the right ventricular, the arterial and the venous circulation. And I think we can pick these up very nicely with the scanner because of the high count rate performance during the early part of the scan. I mean, in this case, on the right-hand side, there's 400 megabecquerels in the field of view of the scanner. So that requires good count rate capability. Next example is a 61-year-old male with a neuroendocrine tumor who received 187 megabecquerel gallium-dotted TOC. Again, we scanned 2 minutes per bed position, and we used the standard VPFX reconstruction. And also here, if we look at the different reconstructions, they look a bit more noisy, these coronal images, but that is because there is so little uptake in the background with these very specific traces. But you can clearly see that there's a number of small lesions that can be seen nicely on the discrete MI images with VPFXS and Q-Clear, but not really on the VPHD image. And there's a number of these in these images. Here we also looked at actually going down to 30 seconds per bed position. You can see that at least until about 60 seconds per bed position, there's not much degradation of the image quality. So that should be possible in the future. Next example is a 67-year-old male that was evaluated for metastatic prostate cancer. This patient received 538 megabecquerel carbon-11 acetate, and of course we have to give a bit more here because half the radioactivity has decayed before we actually start the whole body scan. We scan for 3 minutes per bed position. You get this very nice maximum intensity projection images. And what is interesting here is I think that you see a different effect of using Q-Clear depending on which tracer you use. So here we can actually go up to a beta factor of 700 and get very nice images. And again, you see a lot more detail in the MI images with Q-Clear and VPFXS compared to the VPHD image. And I think what is nice with acetate is that with the high beta factors, if you go down to 1 minute per bed position, you get basically the same image quality. Final example is a patient, 75-year-old male again, who was also evaluated for prostate cancer bone metastasis, received 215 megabecquerel sodium fluoride, 2 minutes per bed position. And of course, this patient should not be so difficult to diagnose with a regular scan either. But you can see this patient was actually also scanned on the Discovery IQ, I should say. So for comparison, I show you these two images. On the left-hand side, the IQ, on the right-hand side, the MI. And you see the enormous improvement in contrast in these images between the IQ and the MI. Here, Q-Clear really offers also sharper images. But on the other end, you can ask yourself, is that really necessary with sodium fluoride? We went down to 1 minute per bed position, and that for fluoride with its high contrast really works excellent. And we also looked into 30 seconds per bed position. And I think if you look at the Q-Clear 400 image, that still has almost all the information that you had in the original 2 minute per bed position image. So that looks very promising as well. I finished with another sodium fluoride case. This is a patient that had a jaw prosthesis where we want to use fluoride to actually look at the bone formation at the prosthesis site. And on the left-hand side, you see an OSCM image, VPFXS. On the right-hand side, a Q-Clear image. And you see how much nicer these small areas of sodium fluoride uptake are visualized using the Q-Clear here on the Discovery MI. And one of the things that is great here is that we have the system with a 128 slice Revolution Evo scanner, which has smart metal artifact reduction. And as you can see here, there's no artifacts at all on the CT images around the jaw prosthesis side. And you can actually make these very nice images that in red show the prosthesis. You can actually see the screws. And the green is the fluorine uptake around it. So the CT scanner is really also of fantastic quality with the scanner. So in summary, the improved sensitivity and timing resolution of the Discovery MI will allow us to use lower patient doses in those patients where we think we prefer that. We can also use shorter scan times and have a much higher throughput of patients. And for a site like Uppsala, where we do a lot of scans with carbon level traces, a lot of research scans, dynamic scans, the increased sensitivity allows us to better use the improved spatial resolution and contrast in neuropet, cardiac PET, and dynamic research scans. Also, the combination with the state-of-the-art CT scanner will allow us for a large reduction in CT doses, which is especially important when we do research scans, where they only use the CT for attenuation correction, but also in other CT scans, because we almost do diagnostic CT scans with nearly all of our FDG scans. And there's really no limit anymore for the diagnostic CT that we can do with this scanner next to the PET. What is an interesting aspect, I think, is that what we really want to look into is how to optimize Q-clear for different traces, because we really see different effects for different traces there. So thank you for your attention.